Governor John Kitzhaber is one of the most important thought leaders, I think, in American health policy, and whether he was in the Senate or in the ER in the Oregon governor's mansion, the guy's got some really sober, smart, insightful comments, and I'm really honored that he has come to Colorado to be with us here today. So let's give him a round of applause and welcome him to the stage. Sir.
Thank you for inviting me to come out here to Colorado. I actually have a little history here. I served my internship in the early 1970s at Rose Hospital. I assume it's still here. And I want to start with a story. When I was an intern in 1973, I watched a baby die. His mother called him Sam, and she arrived at the hospital in labor. She was malnourished, she was anemic, she'd had no prenatal care, and we delivered this baby in the ER. About 24 weeks, less than 2 pounds. And I was part of his short life from the moment he was born until he died 2 days later. And I remember the final hours standing by the incubator, looking into his eyes and knowing what was going to happen and feeling helpless and depressed. And I remember what a quiet death it was. There was no one there in the room but his mother and a nurse and myself. Nobody else knew about this little baby's 2-day fight to live and never made the news or the evening papers. It was an anonymous tragedy that affected only the people who were directly involved. And I think I remember this baby because it was such a stark contrast to a second death I witnessed a few days later, that of a 90-year-old woman named Gladys who had lung cancer. And she wasn't on my service, but when I was on call in the evenings, I'd sit on the edge of her bed and we'd talk, and I developed this lovely but abbreviated friendship. And she confided in me that she was not afraid of the surgery she was scheduled for to remove one of her lungs. She wasn't afraid of death, but she was afraid of the surgery because she didn't want any more pain. She was tired, she was 90. She just wanted to go home and be in her own bed. And when they called the code on the surgery floor a few days later, I knew it was her, and I raced over there with an intern and a resident and a respiratory therapist and some nurses, and we spent this frantic hour in an effort to save her life. And we failed, and she died, and we ran up this enormous bill for Medicare to pick up. Now, Sam died because we didn't know as much then as we do now about treating respiratory distress syndrome in neonates. But he also died because somehow no one had made the token investment to get his mother the prenatal care that could have prevented his prematurity and his low birth weight in the first place. Gladys died because she was an elderly woman with an incurable disease. She died because she was ready to die. She understood that. We couldn't accept it. And unlike baby Sam's passing, her final hour was not quiet. We put tubes in her throat, in her bladder, we put needles in her veins, we pumped her full of drugs, we shocked her repeatedly. She died. We failed and she died. And I can still remember the contrast between this room full of people with all their sophisticated equipment in a frenzied effort to save someone at the very end of a long life, in this quiet, unremarkable, undramatic death of someone at the very beginning of life. And I remember those incidents, but I never connected the dots. It never occurred to me to ask whether we should have resuscitated Gladys in the first place, whether the pain and discomfort we caused her was actually compassionate in light of her underlying diagnosis, which was terminal lung cancer. Now, those events happened over half a century ago, but they still are a troubling metaphor for the U.S. healthcare system, where every day the story of Sam and Gladys plays out over and over again with hundreds of thousands of unnecessary deaths, almost all of them anonymous tragedies that affect only the people who are directly involved. And every time that happens, I think we are all diminished and we lose a little bit more of the soul of our nation. I don't think anybody wants this to happen. I believe that most of us want or believe that everyone should have timely access to quality, affordable medical care and an equal opportunity to live out their lives in purpose and happiness and win what fulfillment and satisfaction they can. So why then is there such a stark contrast between what we say we want and what's actually going on around us? And I think the answer is fairly simple. We are asking the wrong questions and we're having the wrong debate. And until we can change the focus of our debate from how we get more people access to a hyperinflationary dysfunctional system to how we actually reduce the total cost of care,
these tragedies are going to continue to multiply. So what I'd like to do this morning is offer at least one way we might do that by discussing and understanding the key elements of a sustainable, equitable healthcare system, the barriers that we have to overcome, and most of all, the imperative of standing up and challenging the status quo with innovation and with collaboration. So 45 years ago, last October, I started my career as an emergency room in Roseburg in Southern Oregon. I was 27 years old. I was 4 months out of my internship, and I was scared to death about this new responsibility. And what I remember most was how vulnerable the people were who came to see me. They were sick, they were injured, they were frightened and confused, and they were looking for help. And the most amazing thing was they didn't know me, this 27-year-old punk, but they put their trust and their lives in my hands. And it was an amazing responsibility, and I did everything I could to help them, used every bit of technology I had. It's what they expected, it's what our profession expected, it's what our society expects. And even then, sometimes I failed. On those occasions when I was unable to save someone's life, when someone actually died, then I would walk across the hall. And the hall came in from the ambulance ramp and opened on the right through the big double doors of the ER. And on the other side was this smaller room with a couch and some chairs for the family and friends of people who had arrived by ambulance, and they waited for the news of their loved ones, right? And walking across the hall became almost a ritual acknowledgement of failure for me when I was 27 years old. And it always seemed like this long, lonely journey to cross 30 feet of tiled floor, carrying nothing but compassion and bad news to tell somebody that their husband or father or wife who'd come to me for help was gone. And that poignant intersection between compassion and human mortality is extremely difficult. But it was this very compassion and the humility and caring that went with it that brought me to medicine in the first place. And when I was a medical student in the early 1970s, we were taught that our job was to save lives, that death was the enemy. Death was an adverse outcome, and we weren't going to let it happen. And I was taught that healthcare was this sacred, personal relationship between a physician and someone who needed care. And the responsibility of the physician was to do everything he or she could to help that individual who was in front of them. And for the 15 years I practiced emergency medicine, I think I still do believe that. But in 1978, something happened that gave me a completely different perspective on that. And that was getting elected to the Oregon State Legislature. And for the next decade, I practiced medicine and served in the legislature at the same time. And those experiences brought me face to face with the fundamental contradiction between my responsibilities as a healthcare provider and my responsibilities as a public elected official. So as a doctor, I believed my duty was to the individual in front of me to do whatever I could to help them regardless of cost. As a legislator, I couldn't ignore cost. And my responsibility was to try to get the greatest health benefit for the greatest number of people with the resources I had available. So what I learned is that you can practice medicine one individual at a time, but you cannot develop an equitable social policy one individual at a time. And that is the great paradox at the heart of the healthcare debate. We have created a system that provides unlimited benefits, or one individual at a time, while increasingly relying on public resources to finance the cost of that care. And this is a central part of my presentation today. Public resources are different than private after-tax dollars. First of all, they reflect a kind of fiscal commons. They're raised from all of us, and they should be spent in a way that benefits all of us, not just some of us. And secondly, they are finite. If they weren't finite, we wouldn't have a $1 trillion budget deficit and a $22 trillion national debt. And because they're finite, it means if we spend resources on one set of services, they are not available to be spent on something else. Which means that as the cost of care goes up for some individuals, other people are squeezed out of the system altogether or bankrupted by the cost of care, and we are no longer able to make consistent investments in education and housing and other things that also have a significant impact on health. So this is a system problem, and it can't be fixed unless we redesign the system through which we finance and deliver medical care. So let's take a minute and look at that system to understand why it needs to be fixed. I think for decades, the national health care debate and the state debate to some extent has been polarized by the fact that neither the Republicans or the Democrats assume any underlying change in the delivery model. We either pay for it or we don't, which creates this zero-sum choice between cost and access. And I think the debate has been further polarized by the fact that there's no broad consensus on what we're actually trying to accomplish. As the Roman senator once said, Roman Senator Seneca, no wind is the right wind if you don't know what port you're sailing for. So that's a good place to start. Let's see if we can agree on what we want to accomplish as sort of a precursor to this larger discussion. I think it's fair to say that no one wants to be a patient. No one wants to need medical care, right? We'd much rather be healthy. But when we are sick or injured, we want timely access to quality, affordable medical care. The point is that medical care is a means to an end. It's not an end in itself. It doesn't have any intrinsic value outside its relationship to a health outcome or to alleviate suffering, except as an economic commodity. And as we will see, one of the problems today is healthcare is increasingly viewed as an economic commodity. Furthermore, we know that among those things that have the biggest impact on people's lifetime health status, medical care is a fairly minor contributor. Far more important are healthy pregnancies, nutrition, housing, stable families, safe communities, jobs, and education. In other words, the social determinants of health. But the fact is the cost of health care in the public sector continues to increase. It undermines our ability to make investments in exactly those things that have the biggest impact on health. So if we can agree, for argument's sake, that the goal of our healthcare system is health, not just financing and delivering medical care, then we can capture the policy objective in one sentence: to improve the health of the population through a financially sustainable system that ensures all Americans timely access to quality, effective, affordable medical care and can make long-term, effective investments in the social determinants of health. Now, if that's our policy objective, a system that can achieve that necessarily has 5 key elements. Universal coverage for a defined benefit, with the delivery system assuming upside and downside risk and accountability for quality and outcomes in a global budget that indexed to some sustainable growth rate, and some of the savings being invested in the social determinants of health. Now, a system that can incorporate those 5 elements can take a dozen different forms, but without all 5 elements, you can't actually achieve that policy objective. The biggest obstacle to achieving that is total cost of care and cost shifting. Think about it. Healthcare is the only economic sector that produces goods and services that none of its customers can afford. What else works like that? The only way this works is because the care for individuals is heavily subsidized increasingly with public resources, either directly through programs like Medicare or Medicaid, or indirectly through the tax exclusion for employer-sponsored coverage, or the subsidies for people who are getting care through the ACA exchanges. Thomas Pynchon, in his book Gravity's Rainbow, once said that if they can get you asking the wrong questions, they don't need to worry about the answers. For decades, we've been asking the wrong questions. We've been focused on the subsidies, who pays them, who gets them, how much they are, rather than asking why does healthcare cost so much in the first place. And healthcare costs so much in the first place because of this increasingly relentless focus on maximizing revenue. For example, the unit cost of almost everything in the U.S. healthcare system is dramatically higher than almost every other industrialized nation. We're also seeing this uptick in private equity investors who are buying up the most profitable parts of the healthcare system. And this is a quote right out of Modern Healthcare. These firms are attracted to specialties that promise rich revenue from ambulatory surgery centers, lab, imaging, and other ancillary services, eyeing a 400% return on their cash investment within a few years. And remember, a public dollar that goes to feed a shareholder on Wall Street or to unnecessarily pad a hospital margin is a dollar that cannot be used to expand access or benefits or reduce cost or invest in the social determinants of health. In her recent book, An American Sickness, Elizabeth Rosenthal, who used to be a reporter for the New York Times and is now editor of the Kaiser Health News, I think does a good job exposing this greedy financial underbelly of the U.S. healthcare system. And this book, which I would recommend for anyone who's actually serious about developing a new system, outlines the economic rules of a dysfunctional medical market that includes things like amenities and marketing matter more than good care. There's no free choice. Patients are stuck, and they're stuck buying American. There are no standards for billing. There's money to be made in billing for anything and everything, and prices will rise to whatever the market will bear. This profit-driven system has driven up the price of health care to the point that neither private sector employers or the government can pay for it. But instead of getting together and trying to manage cost, they use one of 5 time-tested methods to shift cost.
either to individuals or to the future. They either reduce eligibility or cut benefits or increase co-payments and deductibles that shift costs to individuals who can't afford it. They cut provider reimbursement rates, often to the point that providers won't see or avoid seeing people who can't pay or can't pay as much as commercial. Or, and this is borderline immoral, we simply shove this into the national debt for our children and our grandchildren to pay. Cost shifting is the way we avoid directly confronting both the fact that resources are limited and the fact that healthcare in the United States has simply become unaffordable for individuals, for employers, and for the government. And cost shifting does not reduce the total cost of care. So in my view, the only path forward is to directly confront the total cost of care by putting providers at risk for quality and outcomes in a global budget that's indexed to a sustainable rate of growth. Doing that shifts the debate from the subsidies to the delivery system and allows us to move beyond this false choice between cost and access to actually cover everyone. Now, covering everyone, or universal coverage, is essentially a financing question. The problem is that most of the proposals today to achieve universal coverage, Medicare for All being a prime example, are pretty vague on the financing part. Essentially, they just give more people access to the current system, which isn't going to solve the problem. The reality, both the political reality and the economic reality, is that expanded access has got to go hand in hand with a reduction in the rate of medical inflation. It's just math. So for the past 7 years, Oregon has been trying to demonstrate that it's actually possible to do both of these things at the same time. It's a really good story. I'm only going to give you the highlights. So back in 2011, Oregon was struggling in the depths of the Great Recession like everybody else, like Colorado. And we had a huge budget deficit, about a third of which was in the Medicaid budget. And it became clear that without replacement revenue, which we didn't have because we had very high unemployment, we would either have to drop tens of thousands of Oregonians from coverage or cut provider reimbursement rates in the neighborhood of 40%. So instead of adopting these two cost-shifting strategies, we came together and said, no, let's look at the delivery system itself. So by front-end loading the resources that we did have into the first year of our 2-year budget, we were able to get that cut rate down to around 10%, which people thought they could manage. But that left a $200 million hole in the second year of the biennium, $600 million if you included the federal match. Our plan was to close that hole by transforming the Medicaid delivery system to get more dollars, more value for each dollar spent. And that was going to take place through this new organization called a coordinated care organization. So these were new organizations that were community-based, a partnership between local providers and local citizens with a local governance structure. We wanted to move away from the narrow clinical model and take a broader view of community health. And we would emphasize local collaboration and innovation rather than top-down regulation. So in 2012, the legislation was passed that created these. And it's important to note that the House of Representatives was divided 30-30, but the bill passed 53-7. This was not viewed as a partisan issue. This was a challenge that faced Oregonians regardless of their political philosophy or party registration. By that time, however, it was clear that even if the system transformation yielded savings, it couldn't happen fast enough to get that money into that budget cycle. So in May, I went to Washington, D.C., and I convinced the Obama administration to give us not only the 1115 waivers to use this new care model to deliver care for the Medicaid population, but a one-time 5-year, $1.9 billion investment to help us make the transition. In exchange for a commitment to reduce the Medicaid inflation rate by 2% per member per year by the second year of the waiver from 5.4% to 3.4%, while maintaining enrollment and benefits and meeting rigorous metrics around quality, outcome, and patient satisfaction. Now, it's important to recognize that that money was not given just to prop up the Medicaid delivery model during the recession, but actually to give us a 5-year glide path to make the transition. So that money gradually went down as the cost savings from the CCOs went up, and that's essentially what happened. And during the first 5-year waiver period, the state operated within the 3.4% growth cap. We added another 385,000 people under the ACA expansion. All the CCOs met or exceeded the quality outcome metrics that were stipulated, and we saved $1.1 billion cumulative total funds over the course of that 5 years, which, if the model continues to operate, will reach about $8 billion at the end
at the end of 10 years. So there's some lessons to be learned here. Excuse me. The first lesson is that it is in fact possible to expand access and reduce the rate of medical inflation, to move us beyond the false choice between cost and access and actually get to universal coverage. But to sustain that coverage over time, all parts of the delivery system have got to be under the global cap, and you need to extend this model to the private market and to Medicare. In other words, we can't address the total cost of care only by addressing a part of the system, Medicaid, for example, or the individual market. And we can't be successful unless we can overcome these perverse incentives to maximize revenue. So let me elaborate. The effect of giving Medicaid to another 385,000 previously uninsured Oregonians had the effect of significantly reducing uncompensated care. So in 2014, Oregon hospitals saw a net income go up $360 million and uncompensated care go down $340 million because of the expansion of Medicaid, right? However, over time, it's very possible that the 3.4% per member per year growth cap will be shifted through increased rates in the commercial market. Furthermore, prescription drug prices are not currently under the global budget, which means that just a few individuals in any given CCO who need a drug that costs $300,000 a year can blow up the global budget. I would suggest that you may face similar problems here in Colorado with your newly proposed public option, which I completely agree with the value proposition involved, but it actually doesn't seek to address the total cost of care, but rather to reduce premiums between 9 and 18% for a very small part of the market, the individual market, solely by capping hospital rates at between 175 and 225% of Medicare. I would agree that hospitals are huge drivers of the total cost of care, but so are physician services, so are medical devices and pharmacy and imaging and lab, and none of those are actually addressed in this proposal. And it doesn't appear to me that there's any way to keep the hospitals from simply taking that reduction in rates in the individual market and then shifting that to people who have employer-sponsored coverage, which will lead to increased co-payments and deductibles, and simply another group of people, a different group of people, will have trouble getting access to health care. Finally, except on the margin, I don't see how this actually helps the 395,000 people in Colorado who don't have any health insurance coverage, and it's not clear to me how it addresses quality and outcomes. Now, these observations are in no way intended to be criticisms, but simply comments to make the point that whether you're in Oregon or Colorado or Texas or anywhere else, we cannot develop an equitable and sustainable system without addressing the total cost of care by getting at prices and the perverse incentives to maximize revenue. So to do that, we need to better understand the role that public resources, going back to public resources, play in propping up our current healthcare system. So in her book, An American Sickness, Dr. Rosenthal, if I can get this tells this story of an uninsured woman in Virginia who is charged $285,000 for treating a subarachnoid hemorrhage, whereas Medicare pays $65,000 to $80,000 for the same procedure, and TRICARE pays about $72,000. So this example illustrates three of the economic rules of a dysfunctional system. There is no free choice. Patients are stuck, and they're stuck buying American. There's no such thing as a fixed price for a procedure or test, and the uninsured pay the highest prices of all, and prices will rise to whatever the market will bear. Now, this is an example of where the fundamental difference between public resources and private after-tax dollars comes into play. There is nothing wrong in a market system to raising prices to whatever the market will bear if the individual consumer is choosing to buy that particular service and if they're purchasing it with their own after-tax dollars, not somebody else's dollars. That's not what's going on here. This woman did not choose this particular facility. She was taken there in an ambulance in a coma, and clearly she didn't have $285,000 of disposable income to buy this particular service, right? In fact, only 8% of Americans use only their own public dollars to pay for health care. Everyone else, 92%, most everyone in this room has their health care subsidized with public dollars. And that becomes obvious when you look at what I call my subsidy map here. These are old numbers, 2017 from Kaiser Family Foundation. So Medicaid is actually closer to 72 million, Medicare's up by 50, but you get the general point. What this shows is that virtually everyone in America has their health care subsidized with public dollars. If you're on Medicaid, you're subsidized with state and federal dollars. If you're in the individual market, you're subsidized with federal dollars. If you're in a workplace-based coverage, it's federal dollars and it's your employer, and if it's Medicare, it's federal dollars. The only people who don't have a subsidy are the uninsured. Now, these people are working because they are making too much to be on Medicaid. And while they don't have a public subsidy themselves through their taxes, they're subsidizing everybody else's health care. And that is the most egregious aspect, I think, of our current financing and eligibility system. And the most effective and defensible way to address that, I believe, is to consolidate the purchasing power of that part of the system that's primarily financed with public resources. Now, I know most providers don't think public reimbursement is adequate to cover their costs, however you define costs. And that's certainly true if you assume you're not going to change your underlying business model. I would argue that that's a pretty dangerous assumption to make, particularly given the disruption happening around us, including aggressive efforts by large self-insured employers to shield themselves from exactly that kind of cost shift, and the fact that demographics are simply going to continue to increase public sector reimbursement as a part of the payer mix. So given those facts, excuse me, I don't know why you drink coffee or water when you're having trouble talking, because we're not actually pouring this down my windpipe, but you think it works, it works. Voila. So I do think it's worth considering that the path to a more sustainable healthcare system actually runs through that part of the system that's financed with public dollars. So what would that look like? Let me give you just one iteration. We would start with the existing public-private financing structure that we have in our current system, including our employment-based system. And then we would modify the three large insurance pools that define the current U.S. healthcare system. So we would create incentives to move to a CCO-like model in Medicaid, and over time, use the cost savings to expand Medicaid eligibility to somewhere between 200 and 400% of the federal poverty level, pool one. We would create incentives to make it easier and more attractive for seniors to move into Medicare Advantage, and incentives, excuse me, and incentives to move Medicare Advantage to some kind of capitated delegated model, maybe similar to the one APG is piloting down in California. Now, for both Pool 1 and Pool 2, we need incentives to make sure that health plans don't just use denials to manage risk, but actually move that risk downstream to providers where they can actually manage the care. And then the somewhat smaller but still robust commercial insurance market would remain essentially the same. And of course, insurers could compete for providing care in Pool 1, in Pool 2, just as they do now in Medicare Advantage. The key to making this work is that the federal government negotiates prices for people in Pool 1 and Pool 2. And I would argue they would negotiate one price. It makes absolutely no sense to pay different amounts for treating exactly the same thing based on which public program you happen to be enrolled in. I would move Medicaid rates up to Medicare rates, and you could actually increase Medicare rates a bit towards commercial to establish the initial global budget, because the point here is not to try to suddenly grab a whole lot of money out of the system, but to reduce the rate of growth down below CPI so that you build up this delta of savings that can be reinvested to support expansion and invest in the social determinants of health. We're not just talking about physician and hospital prices. We're talking about repealing that provision in Medicare Part D that prohibits negotiating for drug prices. We're talking about drugs, medical devices, PT, lab, imaging, ambulatory surgery centers, all these niche markets that have developed to maximize revenue, which is increasingly being financed with public dollars. And it may seem like a radical notion, but if you think about it, I don't think it is. All we're saying is that the government, the public sector, is going to use its purchasing power to get the best value and price for its constituents, which are the taxpayers of the United States. Why do you think insurance companies consolidate? To get more market leverage, to get lower prices from hospitals and physicians. Why do hospitals consolidate? To get market leverage to resist that. The public sector is an outlier in terms of not fully participating in this widely accepted and a widely used market strategy. If we want a market system, let's have a market system. Now, if we were to exercise that today, we'd be negotiating for about 110 million lives, the current population of Medicare and Medicaid. At 200% of the federal poverty level, you're north of 170 million. At 400% of the poverty level, you're looking at like 225 million people. So the result would be a system that's built on our existing public-private financing structure, in which the majority of Americans are in some kind of capitated care model, in which providers are at risk for quality and outcomes in a global budget that grows at a fixed rate. We still have a robust commercial insurance industry. We still have a public-private partnership. And the ability to spread risk over 225 million people, plus a consolidated purchasing power, should allow us to operate within the growth cap. Now, as I discussed earlier, a model that can incorporate those 5 elements can take many forms. This is just one of them. I'm sure there's a lot more. The point is that what we're doing right now simply isn't working, and we all know it. As economist Herb Stein said in what has become known as Stein's law, if something can't go on forever, it won't. Or as we used to say in the ER, all bleeding stops. The fact is that efforts to reform our system that don't directly confront total cost of care and prices and cost shifting are not going to be successful. And the fact is the people who are getting hurt are the people we say that we are committed to serve in the mission statements of our hospitals, in the Hippocratic Oath, in the promises given by people who want to seek public office. The fact is that these people simply cannot afford the current system, and the chasm between cost and affordability is growing every day. And if we can't find the will or the leadership to turn that around, our system is going to continue to unravel, and we are going to leave our children and grandchildren with a staggering burden of death from a society that did not have the courage to invest in them or their future. And let's decide right now that we're not going to let that happen. We need leaders. We need leaders in the industry, and we need leaders in the civic sector, and we need leaders in the public sector. We need leaders who are willing to stand up and offer a beacon of hope and provide voices for reason and honesty and compassion in a sea of moneyed special interest and transactional politics. It's not going to be fun. It's not going to be easy. But you will have the satisfaction of knowing that you stood up and took the reins at a time when only bold, effective leadership will suffice. I'm going to leave you with the words of Bobby Kennedy, whose untimely death in 1968 was the inspiration for my engagement in politics. A few men are willing to brave the disapproval of their fellows, the censure of their colleagues, the wrath of their society. Moral courage is a rarer commodity than bravery in battle or great intelligence. Yet it is the one essential vital quality for those who seek to change the world or a healthcare system that yields most painfully to change. Thank you very much.
Thanks, sir. I appreciate that. Bring me back up there. There we go. Thank you. So what? What odds do you give the current crop of Democratic candidates running for the nomination? What odds do you give them to come up with a meaningful solution by, assuming they win, not a safe assumption, maybe they have a Democratic Congress, not a safe assumption at all, but assuming they had all of the wind at their back, what would they do with it? Whoever gets through it.
So I think that's a really good question, and this is where there's this interesting intersection between policy and politics, right? I mean, if you look at, every poll you take, by a long shot, people are worried about the cost of health care, but they're worried about the cost of health care for themselves and their family. They're not really worried about the cost of health care in the system. In fact, they don't want us to spend less on medical care because they're afraid it will be less on them. And so the way cost impacts an individual is through things like surprise billing, right? Or high deductibles. Those are symptoms of the total cost of care, not causes of it. And you can address all those things, and it will not lower costs for individuals. So my concern is that they're having the wrong debate. They're not really focused on the real problems. They're focused on the symptoms of the problems, which, as you know, if you're a physician, that actually doesn't get you the outcome that you want. But the politics, I think, dictate responding to what people want. So I think if that scenario plays out, my view is that they're going to probably build on, in an incremental way, the ACA. I don't know if you saw DJ put out a little article called Don Quixote Goes to Washington, which in one of his missives a while back. But basically what I've been trying to do is trying to meet with as many members as I can on Senate Finance and as many stakeholder groups and talk about how we reframe the debate in 2021 so that when whoever gets elected, we can have a more rational discussion about the root causes of this. Because I promise you, there'll be a point when we cannot have a debt to GDP ratio. I mean, we're way off right now. And at some point, this debate becomes how we avoid defaulting on the national debt, at which point you'll see some kind of super committee come in that's focused on solving the national debt, and healthcare and good policy and access are not going to be part of that conversation. That would be the point at which things have moved slowly until suddenly they move rapidly. And at that point, we have no leverage, and we are truly going to be victims of a political solution to a very serious public policy challenge.
So regardless of who has the majority in Congress and who occupies the White House, I would still bet money that Washington, D.C. will be dysfunctional.
I would agree.
Doesn't that put a premium on state-level action and state-level innovation and the risk or the courage to, not forget Washington, D.C., but really to take some sort of action at the state level?
Yeah, I think actually that this does have to start at the state level. I mean, the reason that I'm spending that time and energy in D.C. is you want an environment that actually is conducive to letting states take those steps. So if, for example, I don't know if this is possible, if, for example, you were to get alignment between Oregon, Washington, and California. Now you've got one of the biggest economies in the world. You've got the ability, if you're doing collective purchasing for Medicare and Medicaid, to really have some juice in the market. Mm-hmm. Jay Inslee understands this. I mean, healthcare is not Jay's top issue. It's climate, but he understands it. Gavin Newsom, talked a lot about healthcare during his primary. So I mean, if you could start at a state or regional level, or the Intermountain West, right, or the Northeast, and get that alignment. And have honest conversations about what the problem really is and what we collectively have to do to solve it. I mean, I think that then creates a situation where D.C. could be a supporter and an advocate of demonstrating that there is a way forward. I don't see this leaping out of the United States Congress. No.
Yeah. It's not the hub of innovation, the Congress these days. Are you able to stick around and maybe let a few people buttonhole you a little bit? And
absolutely.
Chat and have a conversation. Governor Kitzhaber from the state of Oregon, let's give him a round of applause. Thanks, sir. Thank you.
Thank you.
Thank you.